I am so happy to be here and to see all of you. And when the invitation came a few weeks ago, I thought, oh, I need a title immediately. And I had a bit of a block, and then all of a sudden it hit me, the Commonwealth of Community Health. They all have root words: community, commonwealth, communication. We talk about all these things in our work, and I want to talk to you about how they all fit together for the future. Okay. First, I thought I'd define commonwealth, because it's not much of a word you hear every day. Parent that, unfortunately, our new best friend, Michael Botticelli, left. He could tell you all about the Commonwealth of Massachusetts. Many of our original colonies remain commonwealths rather than states. And there's some really important words in that in this case, defines a form of government, but really describes our core values in the work that we do every day. We have a social compact among all of us and with the communities we care about to help do research to improve the common good, to borrow from the Constitution of Massachusetts. And even bigger than the Commonwealths in the United States is the Commonwealth of Nations that Queen Elizabeth II heads. She is not one of my new best friends, although it might be nice. But what also she had to say describing the Commonwealth of Nations in a recent speech is that it is, and applies to us, is this new conception built on the highest qualities of spirit, of the human condition: friendship, loyalty, peace, freedom, well-being. And I don't know about you, but when I was a community-based researcher, we had to work extra hard, and to quote the late Ann Richards, backwards in high heels in order to get that work done, often doing work long after the bench scientists have gone home and gone to bed. So what are the community health practices? Home health, immunizations. I hate it when people read PowerPoint presentations to me, so I'm not going to do that. But again, from a Commonwealth perspective, every single one of us as citizens in a community, members of a community, we do things to preserve the Commonwealth of Community Health. We now know to cough into our sleeves. We take sick leave so we don't infect our coworkers at work. If indeed we have infectious diseases, we take measures to prevent sharing that, passing along that disease to others. And then there is an array of community something research. There are people who quarrel about the respective merits about any of them, but it doesn't really matter, because what's really important is indeed working with people on the shared effort of improving our health, whether it is interpersonally, through text messages, in clinics, wherever you go. So, who else is in this Constitution of Community Health? We have researchers. Researchers are a big part of that. And it's not just researchers. It's your dean and chief wellness officer who wants you to eat your apple every day. It's the people who run mobile clinics. It's the First Lady of the United States promoting physical activity and healthy eating. The diverse group of individuals is not just our research participants, it's us. And we really need to own that, I think, to move into the next generation of community health. Because we talk so much about what our research participants have to help us design curricula. Well, we've got special knowledge that can help them too. And and extra education that empowers us to explain the research methods, perspectives, and variables that can go into creating powerful interventions. Speaking of those, here is a list of some of those people. Professor Obama, who just came to visit. What have we learned? Biostatisticians, a tribute to former College of Public Health member David Murray, as well as other fine biostatisticians I have known and loved, like Laura Shalaha from the College of Nursing or David Vaughan from Columbia University. We have all sorts of different kinds of longer-running studies. For example, the Nuns' Health Study, much like Becky was talking about the Women's Health Study. We have learned so much over the years about women's health from the Nuns' Health Study, because women, I don't have to tell you that women who don't reproduce are often at higher risk for breast and cervical cancers because they don't reproduce, and yet nuns don't seem to suffer that at the same rates as laywomen. Thank you, laywomen who do not reproduce as well. We have all kinds of vaccines that can prevent diseases. It's wonderful. If you've ever had an older loved one who suffered shingles, I think the shingles vaccine has become such a tremendous blessing in people's lives. And yet there are groups of Americans who believe that vaccines are created to help take out target populations. And we need to overcome that. There are all kinds, our definitions of families are changing every day. This white guy here in the middle, that's Sean Patrick Mulrooney. This guy is he's a member of Congress, a new member of Congress. This is his husband. These are his children. This is my grandmother. You'll notice she goes to the same hairdresser as Medea, which is really interesting because they're at least 30 years apart. I don't understand. But I'm from Orange, New Jersey, which is a majority black community, so maybe that's part of the equation. But I digress. So what you've got is all of these people are experts, and we need all of us to work together in equitable ways to develop additional knowledge. In this circle of knowledge development, you can see here some of the highlights. This is the best circle art I could find at the time. But as academics, we need to look to our target communities. We may know epidemiologically what their biggest problems are: food deserts, diabetes. But if they don't perceive those problems as their top medical issues, it doesn't matter how community-based we get with them, because there just won't be buy-in. And so we may need to address their top issues first before what the epidemiologies tell us are their biggest problems. We work with them on curriculum development. It's so important to work with them on questionnaire design. You want a story? You like stories? Okay. I did a lot of my work with illegal drug users who are, although they may not be very educated, they're very, very, very smart people. And I worked on a NIDA cooperative agreement, 20-something sites, and we had, one of the things that surprised us was that the response levels were very low when we asked people, illegal drug users with less than high school educations, about whether they had had vaginal sex in the last 30, 60, 90 days. Which was surprising because these people also had a whole lot of sexually transmitted infections. And so when a small core group of us got together to do a collaborative research project, we did much more qualitative research on our questionnaire design, and we found out that vaginal sex either was a mysterious word. They didn't know what it was, so of course they didn't do it because they didn't know what it was. They'd never heard of it. Or there were lots of people who thought that vaginal sex meant intercourse with the virgin. And if you indeed are somebody whose life is very sensual and centered on drugs and sex, chances are you weren't going to run into very many of them. So we had these very low reports of behavior that transmit diseases, and it was very, very difficult to figure out. And so our data on the follow-up study was much more reliable and valid and in balance because we came up with community-based phrases that described that particular behavior. So if the research participant didn't understand what vaginal sex was, we could provide them with a list of street words that would describe what that was. And as Becky mentioned, it is so important to include cost-effectiveness plans and to for the community-based organizations to continue, or as the Affordable Care Act rolls out, to see how that can fit into an organization's overall plan for care. When I was putting this slide presentation together, this slide came to me, and it surprised me somewhat. But I think it's really, really important. Just about all the folks in this room, I would say, understand that one person's community is simply another person's target population. And since we're the true believers, we may end up working with some people as we are bridging all of these disciplines through our community, through our CTSAs, to understand that these are not necessarily target populations. They're real people, and with the interventions we deliver, during the data we collect, we are treating them as research participants and perhaps down-home kind of folk. We are not running a Nielsen research lab where there is a tremendous amount of Huntington Bank-like difference. There is academic objectivity in community health research, but there's not a tremendous difference. There also is something in difference between disparity and reality. I think all of us make pretty nice livings. We have pretty good health benefits, and we look to groups of people who do not have that as something that they're lacking. It's a disparity. And yes, there is a disparateness between those two situations. But there's a big difference between a group of people who are lacking something and always have, and so therefore they don't know what they've been missing, and people who, by dint of the Great Recession or something, recall what they once had and are striving to get it back. And there are academicians in this world who miss that point. And are simply I think you were talking about it, Doctor, almost the helicopter people. Hello, we are here from the university, and we are here to save you and bring you bring you tidings of great joy. And it's all foreign stuff to them. So I think these are and the Commonwealth approach helps deal with that, because everyone has different pieces of knowledge and experience that contributes to the common good. So that's the good news. Some of the bad news is that too much community-based research can spoil the broth. In this case, this broth is two different versions of pancit molo. I married an immigrant Filipino, and but I'm the cook in the family, and so my tita-in-law has taught me how to make molo, but that's unimportant right now. Although I can share techniques with you later during lunch. What's important here is that so much of the literature that we publish based on our research projects can't be generalized to the general population. And so it's like, okay, we have this project, we have these results, we did this well, but I'm sorry, there's really nothing you can use out of this study. But we can inspire you to do something similar. And we'll even, since the American people paid for this curriculum, we'll share it with you, but you're on your own to tailor it as you see fit. And people will take it from Appalachia to Immokalee, Florida, with Spanish-speaking migrant agricultural workers. And then Linda Macaulay from Emory will pick it up and take it to her agricultural workers. What I think the next step of community-based, enhanced, engaged, whatever you want to call it, research needs are measures for basic mechanisms that help explain why things work. We haven't done that to date. And what I have felt so privileged about working in OpNet, which Usha described to you, is an appreciation for those basic measures. The basic behavioral and social science constructs are those areas of knowledge that fill in the more research is needed in this regard at the end of our community-based research articles. Those mechanisms have those answers. And so when you find something that works, well, not only do you get consistent, reliable, and valid measures that tell you what works, you can go back to your communities with your reports and say, hey, you people are much more resilient than we thought you were, or here is a protective factor that is influencing your lives, and you'll be able to apply in other areas. You will come to understand your communities better for future projects. And perhaps most importantly, after you've analyzed all the data and whatnot, you don't have to go back to these people and do some focus groups that, it's all post hoc and it's getting in the way of analyses, and you're only going to get semi-reliable results anyway, because it's just a few focus groups with some of the people who participated giving you their opinion of what worked. So what is basic behavioral and social sciences research? I'm going to give you NIH's definition. You can read it here for yourselves, but we are looking at fundamental mechanisms. Why are these people here? Becky already talked to you about the strength of research in model animals. We can do things with them because of either their life cycles are faster, all sorts of other reasons. And so we have some of my favorite model animals here. We have children walking to school. I've already talked about the power of the Nuns Health Study. Does anybody know who this man is? No, this is Congressman Adam Schrock. I don't remember where he's from off the top of my head, but as you can see, he's incredibly fit. Obviously, basic mechanisms can explain why people continue to exercise because it makes them feel good, because it does diabetes, because they find a deeper pleasure in it, which is a measure we don't necessarily capture, but also I include that picture because what are the basic mechanisms that lead a member of Congress to display himself half naked on the cover of a national or international magazine? I really would like to know that. I'm also jealous, but perhaps if I had abs like that, I'd expose myself on the cover of a national magazine and get into the supermodel business. In NIH, we divide basic research into 3 areas. The first is behavioral and social processes. This is not an exhaustive list, but it's pretty inclusive. And so we have both individual and social processes. We learn a tremendous, whether it is the power of families cooking together and eating together, so it promotes a healthier diet and also time together. We can learn about sleep from Syrian hamsters. We can learn about family formation, particularly matriarchal family formation and development, and also spin-offs from elephants. Biopsychosocial research is the official second type of basic science. It is a 20th century word, as you know, but when Congress required NIH to create the definition of behavioral and social sciences, it required us to do so through a public process. And given the money, the lack of money we have these days, another public process would interfere with the money we could spend on grants. So the biobehavioral and biosocial research are more 21st century words to describe these kinds of this kind of work. You can see they relate to one another through a Venn diagram. There are intersections. The neurosciences are a big part of that. Behavioral genetics, genetic counseling. Becky was talking about personalized medicine. I can tell you, too, that when it comes to the neurosciences, there are a lot of leaders within the National Institutes of Health who, as you see, they're behavioral neuroscience, cognitive neuroscience. We would claim those as behavioral and social science, but a lot of them would look to that as neuroscience. So perhaps later I'll talk about some funding opportunities, but while I'm on this topic, if you're working in any of those areas, you might be looking at, you might look to institutes and funding opportunity announcements that have a more neuroscience bent than you think you have if you're working in those areas. The last, third and last part of our, as we define it, is methodology and measurement. Data collection, analysis, development, you can read the rest. This is such an exciting time for in this area, and I think for community health. Although you may not be always able to get cell phone service in an Appalachian holler, the fact that we can have these small tablets to collect data and instantly send it to a data collection center allows us to process data faster and get results faster, not just for ourselves, but also when we bring the data back either as a report to community members or to get their feedback because we don't necessarily understand the results. It all speeds the process. And also, when we talk about community engagement, if it is a tablet in which, whether it's audiocasty or they're just reading, you have a much more personalized experience that because so many people sleep with their cell phones and they're almost like an appendage of their body, it is a very familiar and perhaps more yet differently intimate experience to be able to enter your own data and answer your own questions rather than to tell them to an individual. Okay. We've talked a bit about translation already, and this is a famous article that we often quote when we come out from NIH and give our presentations, that changing unhealthy behaviors in advance is the most single opportunity to reduce premature deaths. You can see the percentages there themselves. And dissemination and implementation research is very, very important. Earlier today, for Michael's presentation, I mentioned some best practices interventions that can come from our block grant agencies that you can use. But there's another step in there when it comes to translation, and Becky spoke about that earlier. We have at NIH, we talk about translation. I think we're up to like T7 or T10 by now. But that's kind of how science works, doesn't it? We're always expanding, we're always growing as we get a greater understanding of what we know, and also humbled by the fact of what we have come to realize what we don't know. We're a little short here in this area when it comes to bringing basic behavioral and social concepts into our interventions. And you know much more about T2 than you do T1. And so the sort of the gospel that I'm preaching to you right now is to consider more T1 in your work, because it may mean reaching out to a community of scientists with whom you haven't worked previously, but they have variables and knowledge that will help you understand the communities you care about. And so you will get a better understanding of your communities and research participants, and you will get a greater understanding of the community of science all at the same time. So that kind of brings me back to my circle, that this earlier translational research keeps the circle going, and it improves, although on one hand you're getting closer into the ivory tower with basic behavioral scientists, you are getting knowledge that also gets you closer to the ground and to know your people better. Here's just more examples of the Commonwealth. I love this one. Here's the National Women's Medical Association Convention from 1936. Right now we are so concerned about veterans, their health, getting them back into the workforce. Here's a group of both scientists and NIH program directors at a conference I threw a few years ago. Everybody's college of nursing friend, Linda McCauley from Emory, your associate director for the Center for Research, Laura Shalaha, my director, Bob Kaplan, and other really cool people you may see, friends that you know. The nice lady on the left is the deputy director and former acting director of NHLBI, Susan Shurin, who is a tremendous supporter of integrating this basic research to improve public health outcomes. These are some of the trends that I need to tell you about, and I'm doing so. This is the pediment of Building 1, where Dr. Collins and his immediate staff works. The truth is, NIH is the largest funder of medical research in this country. Unfortunately, most people in the United States don't believe that. I don't know whether we commissioned a poll or someone else did, but apparently we fall like 10th or 15th in the American public's understanding of who funds medical research in this country. More people think Harvard funds medical research than NIH does. So pass that on. The sequestration affects everything and everybody. You heard most recently about it with a change in air traffic controllers, and you learned through the news that Congress had to pass a law to change the redistribution of funds within the Federal Aviation Administration. Congress has not done any such law for or about the National Institutes of Health. And you need to understand that. Sequestration is permanent until there are any new legislation. It is not a temporary inconvenience. I say that because I was in a conference last week, in a workshop last week, and a grantee was mentioning at the workshop table that her follow-up R01 was being held up by the sequestration, and and she simply wanted her program director, Susan Jakowski from NHLBI, in case any of you know her, who's a terrific lady. She said, and I need Susan to take care of this sequestration so I can get my money because we're losing data every day. And it's not a temporary inconvenience. Grants are being held up because we still don't know at NIH how much money we're going to have by the end of the year. The numbers are in flux. But we're still going to have some, trust me. Here's an interesting fact. Over the last 30 years, the average age of principal investigators has increased by the same amount, and 41 is the average age at which researchers get their first R01, which of course is the big time mechanism. Okay, don't cry, because okay, that was the bad news. This is the good, I bring you the good news now, okay? The last slide you'll notice was an upfront picture of NIH's Building 1. You will notice in the distance, I have this picture because I like nature, and the thing is, see this thing in the distance? That's Building 1, just from another perspective on campus. So this is, you can still get there. You might have to go over the river and through the woods, but you're used to that because you have the Oligotangi, right? That you have to go over. Only this is smaller. Okay. NIH has revised its applications and the review process so that innovation and potential for change, for significant impact on science and the public health is the main priority. Some of you may have heard old-timers complain about, oh, they reduced the number of pages, and I don't, it's just awful because it's 12 pages, and, but, even back when it was 25 pages weren't enough to contain all of my brilliance. Do you know any of those people? Yeah, okay. So we didn't just shrink the number of pages, we also restructured the application to support that first bullet I told you about. The big argument you have to make is your really cool idea that is going to make a tremendous public health and or theoretical impact. It is less important how you get there. Nobody, they'll want to know how your N is powered, but you don't have to explain to them what an ANOVA is, the way that they once expected you to. Something else that we are doing in order to get old people out of the business is a consistent practices of, well, or at least to make room for new investigators. Because that's a much more, not only is it a kinder, gentler way to put it, it's also the truth. We weren't always consistent across our 24 institutes and centers on how we encouraged funding of early stage investigators or new investigators for R01s. And we are finalizing that even as we speak. I think that OpNet's funded someone who was around for so long that with an R01 that I think he is 60-something, and when I brought that grant to the IC directors who comprise my steering committee to approve that for funding, they said, oh my God, he's never gotten an R01, he's been around forever. So it does happen. We are also working quickly on research diversity, not simply personal characteristics of human beings, but also careers. We do a great job at cloning ourselves or training people to be somewhat like us with a twist, or maybe a couple of olives. But we are also, it is not possible, given how science has developed with lots of postdocs and lots of labs people. There aren't enough faculty positions coming available in the next 10 years in which everyone will be able to get that same kind of job. And so NIH is preparing funding initiatives for training programs that will enhance curricula at perhaps Ohio State and definitely elsewhere to help expand the possibilities for people who receive doctorates. And we are also responding to investigators who have these hot new ideas. So you have heard this probably from any NIH person who's done a grants personship workshop. Contact your program directors. They love to be heard from in advance. They don't love to be heard from once you send your application in or you get your summary statement later. They really can't help you. What they can help you do is say, wow, what a really cool idea, but Susan Shorin has said, and actually this is true, she said at a meeting, she said, as far as I'm concerned, NHLBI doesn't need to fund another school-based obesity reduction, physical ed promotion application as long as I live. We've just done enough of them. And so a program director you might contact might give you news like that, or say, we've done, we have funded 10 grants, that was our plan. If someone doesn't volunteer, but program directors talk to one another. And so that person might say, but my buddy Paul Cotton at the National Institute on Nursing Research, he was just telling me the other day that he's looking for this kind of stuff. Or if this program director says, I'm sorry, I don't, we're just not doing that right now, ask for a referral, like the good book says, right? And you will receive one. And then if you ask for that referral and you receive one, ask if you can drop that program director's name. So you can say, Susan Jakowski told me to write you. That buys you, obviously it buys you credibility. It also demonstrates that you understand the insider's system and you already have gotten some scientific feedback on your idea. It helps you tremendously. If you are a younger Turk, we offer all kinds of fellowships and training. If you have young people interested in science, we have postbacks. It's a wonderful program. I wish I'd known about it back in the day. But it provides time in any of our labs, 1 to 2 years, for postbacks to be exposed to a whole range of either bench science or our behavioral and social programs that we have, to see if these people indeed want to go to MD and or PhD or both programs. If you go to the training.nih.gov, there are also a range of fellowships. There are the Kirstein Awards. Ruth Kirstein died a few years ago. She is an NIH legend. She was the first woman to head an NIH institute. She had been our acting director multiple times, and she was very, very concerned about growing our future and promoting women, promoting minorities, bringing youth who haven't necessarily been involved in health research before and their families haven't had those role models. Here is a whole series of career transition awards, and it runs the gamut, just like that slide I had previously on the left. We have KO1s, which I'm sure you have all heard of, all the way through topics that may apply to you and your situation. Perhaps you're a mid or senior career scientist who wants training in genetics. Some institutes are going to offer that. Or you've got somebody who doesn't really know human subjects research and wants to become a patient-oriented researcher. And if you indeed are a younger investigator, we have what we call inside, and I don't know if you've heard of it, the K99 ROO, or as we call it, the Kangaroo Grant. the pathway to independence. It's a K award that can transition into an R01, particularly for someone who is wrapping up a postdoc at one institution. It would allow him or her to convert that grant to an R mechanism once she or he lands at a new institution as an assistant professor. Not all NIH institutes offer these Ks at any different time, so you do need to check them out, and if these things are going to be posted, you can see that link up at the top that'll take you to the Career Award kiosk. Whoops. Okay, more funding opportunities. OBSSR coordinates behavioral and social sciences research for all the institutes. We do that out of the director's office. We keep a running list of current funding opportunities. That's the first link. If you're in that neighborhood, you also, if you haven't already, signed up for our listserv, which weekly or when it hits a certain number of new funding opportunity announcements, we send those out on a listserv. If you're interested in the basic sciences, that second list will take you to, quote unquote, my webpage, where we have 3 funding opportunities for fiscal year 2014. The third listing is basically what people used to know as the NIH guide. You can search all sorts of different ways. There's a very nice text box where you can type in all sorts of different search words. Although you might have to weed through a couple of pages, I have found that when I have done that, trying to help other people, I have found funding opportunities I didn't know existed and apply to the people that I'm trying to help. So sometimes the serendipity search works. I believe good research is good research. It doesn't really matter who funds it. And so that's why I included these latter 2 resources for you. If you're interested in youth and delinquency prevention, the Department of Justice might have a grant opportunity for you. If you're interested in healthy eating promotion, USDA's Agriculture Research Service might have a grant opportunity for you. You need to be more creative than ever. And PCORI, it's formed out of the Affordable Care Act. PCORI is funding research that NIH is funding research that partly NIH is letting it pick up, and ARC is also phasing out for PCORI to fund. And of course, as PCORI becomes more flush, as more people start buying health insurance, they indeed should have more money to fund you. Where are we? Okay, I will go through this stuff very quickly. If you're not familiar with NIH's scoring process, we use a 9-point scoring scale. Magic number 9 there on the right. In NIH grants, the lower number you get, the better off you are. So a 1 is exceptional, a 9 says you better rethink things. These are the core criteria that we give our reviewers. And the applications are organized by these core criteria, and we ask our peer reviewers to answer these questions when they read through your applications after they have taught their classes, after they have worked in their labs, after they have met with their project managers, kissed their spouses, made dinner, put the children to bed, worked on a manuscript. 11, 12 o'clock at night, these people are doing this kind of work. So you need to make it very, very clear for them and easy for them to read. It's not, they're doing this at 11 o'clock because they care, because otherwise they'd be going to bed. They don't make any money. They are doing this because they are smart people of goodwill who want to help and also want to stay abreast of the science. The shaded thing under innovation, are these concepts, approaches, methodologies, whatever, are they novel to one field of research, or in a broader sense. It's another example of the impact that they're making. And we do like high-risk, high-impact applications. That's our R21. If indeed this is a high-risk, high-impact application, do you have strategies in there to help ensure that you get a high impact rather than a high-risky, towering inferno? The environment. This is where, you know, do you have the support both from your home organization as well as the entire group of people? Here's another helpful hint. Your biosketch. In your NIH biosketch, there is a place for a personal statement. There are too many researchers who submit biosketches with boilerplate personal statements. This is a big mistake because that is a place where, because there's a whole there's a whole criterion based on the research team and you, and that is extra. So a personal statement is extra application space in which you argue why you are the perfect person to do this particular job bid on this proposed research project, and how your skills mesh with everyone else proposed, and how the 5, 6, 8 of you are uniquely poised for this amazing synergistic explosion of innovation to cure everyone in Ohio and Appalachia. It is a missed opportunity if you don't do that. And if there's one thing that reviewers look at, it's biosketches. Too many people don't think about protections for human subjects. They're real people. You need to account for why you're including some and why you're excluding others. If there's something that's going to throw up a red flag, if you're involving urine, if you're drawing blood, if or any of these things, these need to be included in research projects with human beings. You'd be surprised the number of applications who come through that don't do that and then get red flagged. Okay, that's me. So, whoops. So there is a list of tutorials that you also can check when you get your hands on this slide set. I have about 8 minutes, so why don't I stop talking and I can answer a few questions.